Advanced Professional Practice, Unit 1, Part 2C. So we're still talking about self-regulation, and I thought I'd include the process we went through for applying for self-regulation, just to give you some background. This is personal background. You probably don't need to know this, but it was an interesting turn of events when I ran for the board for the Ontario Paramedic Association. I ran for the board, so there was a conference going on, and I ran for the board because I wanted to play a role with the National Occupational Competency Profiles, and the only way to do that was to get on a provincial board. And so I went to one of the board members and said, can you put my name in for a nomination to the board? Because I was going out for dinner with some old friends and a beer. And when I came back, she said I'd been elected to the board. Okay, great. The next day, the group wanted me to be present. I said, okay, sure, no problem. And about a week later, when the dust started to settle, I contacted the previous president and board members and asked them what the status of self-regulation was, because I had assumed that the application had gone in and it was all kind of a done deal and we're waiting to hear, but I learned that it had not gone in, to my surprise. And I really had no particular interest in getting involved in the self-regulation thing because I knew it was going to be political and unpleasant. So I was quite surprised. So I contacted the Health Professions Regulatory Advisory Council to find out what our status was. And they said, well, you're going to need to get your application in 3 months. And I said, okay, well, just send me the application and I'll fill it out. And they said, well, it's not quite that simple. First of all, we don't have one prepared for you guys, but the one that exists on the website is probably adequate for now, and you can get started on that. And I said, when you say get started on that, isn't this just like a one-page, fill in the blanks? And they said, no, it's got to be about 80 pages, and it has to be lit searched and APA referenced. So I was quite surprised. So by chance, I ran into Chief Mike Nolan in Ottawa a couple of weeks later for an event, and I told him my situation, and he said, well, I've got a lady who's doing some work for me who is a really hard worker, and why don't I release her to you, see if she can help you out. So I met with her. Her name was Maureen, and Maureen suggested that I she said she would work with me. She recommended that I contact a guy by the name of Michael Fitzgerald, who's a PhD, not in health, and he's a dog on a bone and gets things done. And so we hired Mike Fitzgerald and this lady Maureen, and worked with Mike Nolan, and later Pierre Poirier joined our team, and after the application went in, actually, but Mike and Maureen and Mike Cole and I worked on this application day in, day out, and constantly Skyping each other and sending drafts back and forth, and finally put this thing together in pretty record time, and got it in. And actually, when we presented it to HBRAC, they said it was one of the most impressive applications they'd ever received, so I was quite proud of that. And what Michael Fitzgerald, Dr. Fitzgerald, brought to the table was a really unique outside perspective. He was able to look at our system from the outside and see it with a great degree of objectivity and see all the flaws in it, and that's sort of highlighted in this presentation that I'll go over. So the application went in end of 2012, I think, or early 2013, and so we gave a bit of a history of our profession and how we evolved very, very rapidly when you look at us compared to, say, other health disciplines. Nursing, which has been around a couple of centuries, and medicine, which has been around a long, long time. We had our first college programs in 1975. The first advanced life support level paramedics in the province were the critical care paramedics. They were called critical care attendants in 1977 on the air ambulance. And the first ground-based advanced life support paramedics, ACP level, were in Oshawa in 1979. And then there was the ALS pilot project in Toronto and Hamilton, where they trained 2 groups of advanced care paramedics in 1984. And then 1995, the OPA was formed. 1996, 1995, 1996, all ambulance attendants in the province were given symptom relief and defib. And the OPAL study started at that time as well. And so, about 1996, every ambulance attendant became, as you might recall, everyone became a paramedic under the new definition of paramedic. And then in 2001, the National Occupational Competency Profiles were established right across Canada, establishing 3 levels: PCP, ACP, and CCP. So we evolved very, very quickly, very, very rapidly. And so, the question a lot of people outside of paramedicine ask is, why are you guys not self-regulated already? And why is it taking so long? Well, it's not that it's taken so long. We have evolved very, very quickly. There was an application that went in apparently in the 70s, I think even before the college programs, or maybe just after the college programs, and that was rejected as well. But we've come a long way since then. And we've expanded, so we've got lots of new paramedic subspecialties, including, community paramedicine, hazmat, CBRN, marine medics, tactical medics, heavy urban search and rescue, and so on. And so we went over the education for the different paramedic levels in the province, and we talked about the fact that we deal from everything from delivering babies to the very elderly, every imaginable medical emergency and traumatic emergency, and that we perform 7 to 8 of the 14 controlled medical acts, and that we do those independently, that pretty much 100% of what primary care paramedics do, they do independently without consulting with a physician, and probably 98% of what advanced care paramedics do, we do without consulting with a physician. So we're working independently, and it's important to demonstrate to HPRAC that we work independently, because otherwise they would say, clearly you have good oversight, but we really don't have any oversight, because it's just not the nature of what we do, right? The other thing we presented was that we work in a very different environment, and we're under different time constraints. So we're under a lot of pressure to spend as little time as possible at trauma scenes, and usually no more than 20 minutes on medical calls. And we're working under unique circumstances where, we gave some examples. So for example, I gave the example where we ran a cardiac arrest in the middle of winter, and the drug of choice to run as an infusion would have been amiodarone, but the intravenous line was frozen stiff. So you have to switch to an alternative like lidocaine bolus as opposed to something running in a drip. And that we're dealing with other unique environmental situations like prolonged extrications, calling out surgical teams for limb amputations, and that we deal with, we had to demonstrate that we posed a risk of harm. So the number one criterion for self-regulation is, does your profession pose a risk of harm to the public? And the answer is clearly yes. Now, it doesn't mean we're dangerous or nothing like that, but anytime you're dealing with vulnerable clients, or you're performing any controlled acts, even driving patients for that matter, is considered risk of harm. So risk harm from misdiagnosis, drug error, extrication gone bad, driving, crashing, those sorts of things. Those are all risk of harm. And what's interesting was that when HPRAC recommended against paramedic self-regulation, they argued that we did not present a risk of harm because we are regulated, sufficiently regulated. But here's the thing. All these other provinces, Alberta, Saskatchewan, New Brunswick, Manitoba, Nova Scotia, they all meet the criteria of risk of harm, as do we. the question is, what is the best way to mitigate that risk of harm? HPRAC felt the base hospital was adequate. We argued that it was self-regulation because it would be inclusive of all paramedics, not just paramedics who work for paramedic services. And so it would include the event medical medics. It would include the ones working at places like the Ford plant, the AC center, the mining industry, and so on. But they felt that they, I think, didn't appreciate that that was a big issue. So Michael Fitzgerald, with us, we looked at the current system, and he identified some flaws that we all knew existed, but he really brought them to light for us. Starting at the education level. So we look at the education level, and hang on a second here. And we look at accreditation, and there is no need for accreditation. There's no requirement to accredit PCP programs or CCP programs, but there is for ACP. This has always boggled my mind. We have, in terms of regulatory bodies, we have the Emergency Health Services Branch certifies and regulates PCPs, ACPs, but not CCPs. And the interesting piece is there is no requirement for renewal ever. You never have ever have to renew your AMCA. But EHS branch does quality assurance. They investigate and they discipline paramedics. The base hospital certification is required for PCP, ACP, and CCP level, which is good. Annual renewal applies to paramedic service employees only, and they provide QA, CME investigations, and they discipline. So they don't have any oversight over paramedics working outside of paramedic services. So under the current system, MOH is the umbrella organization, and they oversee EHSB activities and base hospital activities. And we argued that we are over-regulated, inconsistently regulated, and completely unregulated as a profession, and gave examples of how paramedics working for two services under the same base hospital have to do double the continuing medical education and double the certification because even under a single base hospital, they're not organized enough to make CME and recertification consistent across the board. So we have MOH oversee EHB and base hospital, and then we have this growing number of people who are unregulated. We estimated about 1,000, but there's probably closer to 3,000. We just couldn't capture them all. So they're increasing in numbers. They're unable to achieve paramedic status. They're really not technically paramedics at all. In fact, there are ACPs working for the OPP Tactical, and they only work for OPP Tactical, and technically they can't call themselves paramedics, although they do. And they have no oversight other than a freelance physician, no mandatory CME, no annual certification. So they're completely off the grid as far as paramedics are concerned. So there's no accountability or standards for these people, and they're not employable outside of Ontario beyond a year after graduation. There's no public complaints mechanism, there's no public input, there's almost no paramedic input whatsoever. So we have the Medical Advisory Council, and this wasn't an argument to HPRAC so much, this is just an argument for the profession, but paramedics don't have a vote at the MAC. They're talking about giving them a vote, but that'll give them 3 votes out of 12 or something, or 3 votes out of 14, whatever the numbers. Or it might be 1 paramedic vote out of 12. So because we don't have self-regulation, we have a lot of barriers. For example, even at education, when we try to place people in the hospital, now we've been doing this for a long time at Georgian, but in the beginning, every time we got a new nurse manager, the response we got when we tried to place students was often, I'm sorry, but paramedics are not a regulated health profession, and therefore they're not part of the circle of care. And we had to explain that, well, we have a medical director, and students are working under his license, and please let us in. Many paramedics are excluded rather. There's no interprofessional collaboration or care, so In the event of a pandemic, for example, where we would need all hands on deck, paramedics would be excluded from helping out at clinics and giving injections and so on and so forth, unless you can get a physician to delegate to you. So I know in some services, the medical director is allowing paramedics to inject co-workers with a flu shot, but we're not at the same table with the adults in that respect. So what we had proposed was a single regulatory body, a complete overhaul of the system, so a redesign of the system. We weren't asking for new regulation, we were asking for a change in regulation. And some of the college main functions include setting entry to practice level requirements, setting requirements to practice as a paramedic, setting up a disciplinary process, and a means of evaluating ongoing competencies. So a college would likely do some of the same things that base hospitals and paramedic services do now, chart audits, the usual things. Slide 24 here. It would be inclusive of all paramedics, which we don't have right now. It would be based on the NOCPs. We would have clinical practice guidelines as opposed to medical directives. They'd look very similar, and they would be developed in collaboration with physicians. So you wouldn't be looking at complete elimination of physicians from the system. You'd be looking at a more collaborative response. So, places like Manitoba, New Brunswick, they meet with physicians to develop their clinical practice guidelines. They come to a consensus, and they publish their guidelines. The impact on the profession, so it would give paramedics professional status, some autonomy and control, stand over standards and policies, oversights and complaints, greater interprofessional collaboration and care, expanded roles, title protection, and no one would be left behind. So paramedics would have a lot more say about their medical directors, and we understand better than anyone what it's like to work in the out-of-hospital environment, and physicians really don't. So sorry, that was kind of rushed because we're a little over the 12 o'clock hour. But did you guys have any questions about this? No? Okay.
No, I'm okay.
Yeah. All right. Well, you guys have a good day.
Thanks.